I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti, I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
57-year-old never smoker with originally resected 1A lung adenocarcinoma, who then has a right upper lobe recurrence with mediastinal involvement 7 years later. Molecular interrogation is consistent with a MET exon 14 skipping mutation. He receives concurrent chemoradiation, but his PET scan 6 months after concurrent chemoradiation shows multiple enlarging FDG-avid right lower lobe pulmonary nodules with a stable right upper lobe mass that was radiated. Is there a role for surgery? Again, complicated case. We originally got a resected 1A lung cancer of the right upper and had a right upper lobe recurrence with mediastinal involvement, then went on to receive concurrent chemoradiation. But then 6 months after that, via PET, we see multiple enlarging FDG-avid right lower lobe pulmonary nodules. Is there a role for resection of the right lower lobe? Tough call, Dr. Lanuti. I know you don't have all the information.
Given the short interval of recurrence, you'd have to make the assumption that this is metastatic disease, and that my enthusiasm for local control of that is quite low.
Okay.
And it's challenging going back, and if you're ever going down that path as a surgeon and you're exonerating everything else, going into that radiated field, it can be associated with more surgical complications.
Dr. Govindan, do you have any problems starting this patient on a targeted therapy? Would you want another biopsy? Given that the biopsy that was done was prior to concurrent chemoradiation and now there's new lesions in the right lower lobe, how would you approach this patient?
Obviously, if there's any, first of all, if there's any concern that this is cancer versus something else, I would definitely biopsy it. If the concern is the histology is going to be changing, that would be less of a problem because this particular patient did not get targeted therapy. So I wouldn't be too worried about that. So it all depends on the scenario. The one concern I have is that if they're asymptomatic lesions that are small sub-centimeter, I would just watch and I would not be rushing towards systemic therapy. But if it is symptomatic, I think the options are to give MET-targeted therapies. But also we have to appreciate that these tumors become resistant to these therapies in a short time. So I would use them only when absolutely necessary. So it's certainly an option. I would use it if they're rapidly growing or they're symptomatic.
Okay, all good points. So doesn't seem like a role for surgery here, and there's a potential role for MET-directed therapies, but if the patient's asymptomatic, maybe holding off and following until they become symptomatic.